one thing for sure, I don't think we have the perfect drug yet, right? Every drug has different side effects, different issues with it. So we still need a lot of HIV research. We're not done yet, right? We still need to find the perfect drug. As long as there's no cure, we have to make the lives of our patients better and better.
Grace, as you mentioned, the increased efficacy and tolerability of modern day regimens, along with the increase in life expectancy in our patients, has really allowed us to shift our focus to the impact of antiretroviral therapy on comorbidities and overall health. Of particular concern with modern ART is weight gain and the potential metabolic complications that may result as due to that weight gain. We do have some recent data that's come in on ART and weight gain. We have really great pooled analysis of randomized control trials, both in treatment naive patients and in patients who are already virologically suppressed and switching to alternative options. I think that the weight gain is significant. It's probably multifactorial. We're learning more about it every day. We're needing to go back to the initial trials and do sub-analyses and collecting data to really understand what the implications of that weight gain are. Is this weight gain metabolically neutral weight gain, or is it associated with increased risk for comorbidities? We do now have some data showing that, in particular, the INSTI regimens are the weight gain that we see in sub-studies, for example, of the advanced trial, showed that weight gain was associated with an increased risk of cardiovascular risk. There have been increased risks of hyperglycemia and diabetes, especially with the INSTIs, particularly dolutegravir. And so I think that these are complications that we need to study further, and our work is not done. I think one thing to think about is, do we really know, in some of those studies, we've seen certain populations disproportionately affected, in particular women, people of Black race, people with more advanced disease. Do you know why the magnitude of the weight gain signal is different in some of these populations, and how does that affect how you're selecting regimens, either for initiation or switch in your patients?
Yeah, very good question. The $1 million question now, right? Individualizing treatment. So you're absolutely correct that women, and ironically, you and I think had the first study that looked at a large number of people who were participating in ACTG studies, and even before all the INSTI and the weight gain, we did find that women, regardless what treatment they were on, gained more weight than men, right? And now we're seeing it again in all the studies. So you're right, we have more and more data. And I think the data we have in naive is much stronger than in switch studies. Yes. So in naive, it is clear that when you start someone on treatment, it doesn't matter what you start, they're going to gain, as a group, they're going to gain, some weight, more with integrase and more with bictegravir and dolutegravir. So unfortunately, the two that are really very effective that we like are the two that are associated with a little bit more weight gain than the rest. And on the NRTI side, there's no question in my mind that TAF gives a little more weight gain compared to tenofovir, for example. So I do think integrase inhibitors selectively, at least give a little bit more weight gain as a group. But I always remind people, when we look at study, even the studies I presented, you present the average increase in weight gain, right? You forget to talk about people who don't gain weight, the people who lose weight. I mean, I remember in 5260S, now seems like so long ago, a few years ago, we had about 35% of patients who participated were undetectable. So it was successful treatment, but their weight did not change or lost weight. Mm-hmm. So imagine, lost weight, even though they're, undetectable. So when you talk to people about, you can gain weight on treatment, I think we have to be clear with them. It doesn't mean everybody's going to gain weight, right? Right. All it means is mainly the first year or first 6 months, even after you start treatment, you have to be so cautious about what you eat, exercise, do your best, expect that you may be one of those who will gain some weight, So you got to really be careful about what you eat and what you do. I think the first period is the worst, right? The first year. After that, it seems to plateau after that. I mean, they still gain some weight, obviously long term, but if we can get them through that first year, I think will be good. So it is something to worry about, but I don't think we have to over exaggerate it in the clinic. I think we have to be careful with the discussion with the patients.
I agree 100% with everything you said. And I think that, really emphasizing the role that they can play in preventing that weight gain, because exercise and diet are going to have overall positive impacts beyond weight. And so I think I agree. Yeah. You mentioned weight that occurs with switch as well. What do we know about the role of TAF and switching to, or TDF to TAF? I think that's come up a lot in the literature recently. People postulating some of that, the losing the weight suppressive effects of TDF maybe playing a significant role.
Yeah.
What is your take on that?
I'm a big believer in that. And I mean, I'll tell you why. You put even the prevention studies, right? And you see whatever you compare versus tenofovir make you lose weight, even versus placebo. Yeah. People lost 1 kilo on average after a year of tenofovir. So tenofovir, we shouldn't be happy that it has a weight suppressive effect, because it may be causing mitochondrial toxicity at lower level in the fat, for example, causes damage to the fat that people, fat cells are damaged. That's not something I like to see. Yeah. So I think what happened is when we started switching from TDF to TAF, we noticed whoa, people are gaining weight. I think, most of that weight gain, if not all, but most, is that you lost the TDF suppressive effect. So to me, it's a healthier thing to be on TAF rather than to be on tenofovir and cause damage in the fat cells. Yeah. And I think that's lost from the, people, TAF, I don't want to use it. It's weight gain. Right. I don't believe in that. I still believe that TAF should be used, and it's way better than using a toxic drug like tenofovir. Yeah. And I think we could say the same for efavirenz too. Yeah. So Sarah, one new thing is there's some changes, right, in the way we think about dolutegravir in either pregnant women or young women of childbearing age. What you want to summarize what happened recently? Yeah, sure. So a few years ago, we had compelling data from the Saponimo trial showing a significant increase in neural tube defects in patients who were on dolutegravir, most importantly prior to conception, because that neural tube is formed so early. And so many of us were not recommending dolutegravir in women of childbearing potential, any woman considering future pregnancy for that very reason. Fortunately, we have updated data showing that the increased risk of neural tube defects is really very small, and the advantages of dolutegravir, with it being once daily and well tolerated and inducing such a rapid response, really, in this case now, the benefits outweigh the risks. And so dolutegravir is now something that I am encouraging all of my women of childbearing potential, if they're already on it, to keep taking it, along with sort of the usual advice and guidance that we give any woman who's thinking about conception, to take a prenatal vitamin and make sure they're on folic acid and other things. Yeah, luckily not penalizing for women. Yes. About their kids. So yeah, that's a good new advance for pregnant women or young women overall. I think some of the data that made the really struck me was some of the data from IMPACT and the treatment pregnant patients who were on TDF and efavirenz gained less weight. And in fact, they weren't gaining the expected weight in pregnancy, and they had adverse outcomes. And so I think we can draw a lot of comparisons between perhaps the TDF weight suppressive effects and then the efavirenz weight suppressive effects as well. Yeah, you're exactly right. I mean, that study reminded us it's not good to lose weight, right? When you're pregnancy, the healthy weight expected, if you can't reach that, that's not a good thing.